Okay, good afternoon.
Professor Sharma Kini, welcome to Brazil.
Yes, well, I'm
Hi,
clearly
Dr.
we
Sharma
thank.
Kini.
Yes, I think they're trying to adjust everything at this time. You can see us
Perfect.
and we can hear you very well. What about
Wonderful.
you? Okay, beautiful.
Perfect.
So
we can see and hear. We have a great panel here to discuss your cases. Roberto Botelho, who you know very well, also Fábio
Yes.
Brito, Rogério Sarmento, and João Braglioli from Miami, and the moderator, digital moderator is Dimitri.
fantastic, fantastic. So clearly we really thank the society to give us opportunity from Mount Sinai with my team. Myself, Dr. Kini, and we actually, I don't know whether everybody can come on the screen, look into it, all cath lab staff with the fellow. We have two fellows here, Dr. Amit Huda and which is a interventional fellow and both cath and interventional research fellow, and the rest of the staff, which are ready to show two cases. One is a very calcific left main with moderate LV dysfunction, and then second, we will be ready with the TAVR case. So that is our goal for today. The TAVR will be valve in valve. So if we that okay, we can show our presentation of the case just very quickly.
Sharma,
We can, yes.
if you allow me just 1 minute, before I thank you for your efforts, just to let you know that after attending your course for 4 consecutive years, I'm so glad to share with the of your team, you and Kini and Mount Sinai, and let you know that there are more than 2,000 Brazilians connected to your transmissions. And we
Beautiful.
hope to discuss with you that we can continue this opportunity for every last Tuesday when you transmit worldwide your wonderful case. Thank you so much for your efforts.
No, fantastic. And of course, to be that, of course, this year we didn't have our live CCC complex symposium in June. Hopefully next year will be. But I know that we track our monthly webcast participants, and Brazil comes quite up. So it's a fantastic opportunity for us. And hopefully after this, even will become bigger. So if we can show the slide, yeah. So clearly, we are the two operator for Sbhci 2020. So this patient is a 79-year-old who has multiple medical problems and presented with the angina class 3 with positive stress test about few months ago. And after knowing 3 vessel disease and had some interventions in the past, now has progressed further with the left main and ejection fraction 35%. Rightly so, patient was referred for heart team discussion with surgeon, particularly for cabbage. Patient did have discussion, but patient had a prior CVA and atherectomy, recovered from it. And after discussion, actually because of issue about the CVA issue, so they felt the family decline cabbage. And why it is? Because of why did we send this case is because this extends to CAD, which we can show the angiogram now, which we have taken a picture. Wait 1 second. Yeah, now very peripheral arterial disease you can see here. Now many times, of course, patients with the complex left main, even the EF is about 40-45%. We do use Impella, but in this particular case, patient has a PAD, already have stents, has the subclavian stent, left-sided disease also. So we felt that this case, we just go without any support, largely because of peripheral vascular disease. Initially, patient has high creatinine, but now for last week, which I had not added in my presentation, because patient was put on dialysis, creatinine went 4+. So Anu, you want to show the angiogram now?
So this is the femoral artery. You can see a lot of disease already. EF, the EDP was about 25. So this is a not pigtail, but just a GR catheter, 45 EF. And this is where you see is the right coronary artery that's totally occluded, which is completely collateralized from the left system. So you see the LPL that is total on the circumflex and maybe moderate disease of the ostial circ, but important is the left main, heavily calcific distal left main with a nodule with significance in the ostial LAD. So you see there is also stent in the proximal circumflex as well as the proximal LAD, which are patent. So this is where we are. So left main and 3 vessel disease, like we discussed, I mean, if patient did not have peripheral vascular disease, this could have been a good case for LV support.
Yeah. So this is the case out of even without relay in day-to-day or practice, we'll use Impala in this particular case, or could be a trial case. It cannot be, right now there is a trial called SHIELD 2 ongoing, comparing the PHP, which used to be now with the Abbott St. Jude's pump, comparing with 2-to-1 randomization with PHP versus Impala. And this case in our lab, whether trial or not trial, because of the short of the peripheral vascular disease, we have used Impala because this is a very complex left main. Now, the angiogram, we actually saw the LPL. Back in last angiogram was in July. So we are talking about 4 or 5 months ago. That time RC had been closed for a few years. So this LPL actually is a new occlusion. LPL is a new occlusion. And of course, the left main and so has become progressed. This took about 4 months for this patient to decide and finally say no, and then came to our table for the intervention. So very calcific, big chunk of calcium, large vessel, about 5 millimeter. Angiographically, I put it as severe calcium because both tram track in there, little ulcer also even at the ostial LAD. And there is a stent, as mentioned, both stents are patent, but they are further down. So what we have done is, just to show and understand the extent of the calcium, Dr. Keeney has wired with a run through, and we are ready to do the IVUS in this particular case. Okay. And then you can ask other question. Patient has the heparin, Angiomax, and most of the intervention still radials we do with the heparin, but otherwise we still use quite a bit of bivalvular in our lab. Now this is the
Okay, start the IVUS. Angiographically, definitely it's a tram track severe calcium. Based on the angiogram, I think plan would be that this patient definitely needs rotational atherectomy. And here we are in the distal left main chunk of calcium. So that's that eccentric chunk of calcium that you see. Right? Okay.
What about the ostial circ? The question will come in this particular case, is there a disease in the ostial circ?
For that, you have to go into the circumflex.
No, but can we see from?
No. Okay, show us again at the distal left main and a cross-sectional area there. Yeah. Yeah, right there, right there. Yeah. Yes.
Fine cross.
So in case you select to use rotablator in this case, what does burr size that you would choose? The lumen doesn't seem so tight. There's a lot of calcium, but I think that you're gonna have to select a larger burr, right?
Yes, a very good point. Yeah. So clearly, so
I think
rotawire will go side by side. Let's try the rotawire. Yeah, that's okay. We can now go. Very good point. So clearly, which I say, in a large vessel, even your eccentric calcium. So many times the burr will have a wire bias. So it's, it will work in your, particularly in your favor. But this has a big chunk on the top, and even doing a 1.75 is a lumen already there, or 2 millimeter. So that will not be enough. So what we have planned here in this particular case, that we do 2 burr. About 90% we are single burr, about 6-7% 2 burr, and about 2 to 3% use 3 burrs because the type of the cases which are referred here. We do about 22 to 24% rotational atherectomy per year. Of course, like every month. So we do about 650 to 700 of our 4,000 interventions, the rotational atherectomy or orbital, basically. But the key is that, yes, plan here is to use 2 burr, 1.75 and 2.15. Now, if I would have put an Impella, I would have gone with a 2.15 directly. But here, you don't know because, EF is mildly decreased, about between 35 to 45% various readings. And so we felt that let's do 1.75 quick, and the real ablation will occur from the 2.15. Other technique, whether should be orbital atherectomy at this position, is another device. And of course, we don't have FDA approved yet. IVL, but that many people will use that also. Could be a device, particularly in this kind of situation, but such a big chunk of calcium, whether IVL will really be effective, need to be seen. But yes, those will be the another. But here, our plan is 2.15 bar, but we are using 1.75 intermediary just because we do not have any hemodynamic support in this particular patient.
So what I did was use a rotafloppy wire, just wired side by side. For some reason, we have a VL30 guide. Even this is a little large guide for this patient. It's not coaxial. So if you saw me the way I was wiring, it was just the guide was just in the ostium. When the guide is totally engaged in the ostium, we do see ventricularization. That could be because it's a large guide in our left main.
Yeah.
So
it's
after we have placed the
it's an 8 French guide, and there is an ostial. If you see in the aleocaudal view, actually you can see there is a calcium at the ostium also. See that there is definitely a calcium chunk of calcium. So just to present our particular complete case here, if we can go back to slide so that presentation of the case is complete. So we have done, we have presented the baseline. Now, as you know, that clearly these complex cases have to have our heart team discussion. So this particular case had a heart team discussion. We talked about 2 important points which require syntax score and STS score, which are both high and which led to the left main artery. As you can see that although it is the maybe appropriate, but clearly it's appropriate after the heart team discussion. So this is where now that the cabbage was not declined after the heart team discussion, and clearly for one important point here was the CVA. All the patient was worried about when saw the surgeon about the renal failure issue also, but we know that this patient actually renal progressed anyway, and now is on the dialysis. But yes, most of the trial of comparing cabbage versus PCI have definitely shown less AKI with a PCI. Same thing trial for the TAVR as well as for the surgical valve, that you have lower AKI with the percutaneous approach compared to the surgical. Okay. So now we have 1.75. Yeah. Yeah, question is RCA. Yeah, RCA question is basically, since RCA has been closed for about 5 years, now surgeon, we probably won't do anything, but surgeon wanted this patient to have cardiac MRI. They did it. And inferior wall, according to MRI, is no viability. On echo also, there is no viability. And when they did a original, the nuclear myocardial perfusion back in June, before the cath we did, also showed no viability in the inferior wall. So the feeling is, in this particular case, let's go where the money is and leave the RCA, which we know documented, closed for about 5 years at the time when both CIRC and LED interventions were done.
So now we have the rotaplator, which is 1.5 bar, close to the left main.
For you.
No, it was exactly that question about the viability of the of the inferior wall.
We did. Yep, cardiac MRI. Yeah.
So before we start Rota, we'll be doing 3 steps. When we went up, this is the Rota Pro, the newer generation of the Rota. So already on Dyna, we tested, it was about 155 RPM or so. So do your 3 steps. So you have the knob. So move backward, forward. You release the tension between the Teflon sheath and the burr. The second one will be just the burr backward, forward. On the wire, this is any tension between the burr and the wire. So the tension between the Teflon sheath, the burr and the wire is removed. And the last step is on Dyna, just tap. So even if there is a forward movement, it will be at the Dyna speed, which is between about 70,000 RPM, but not the full rotor speed. Once that is done, you can switch off the Dyna out and start burring. All you do is press the button and slow pecking motion. You see here? You touch and come back, touch and come back. Every time, few millimeters. And at the same time, you're watching the blood pressure and listening to the sound. So we are about 18 minutes, we stop. No more than 20 seconds per 18 seconds. So no more than 20 seconds per run.
Yeah.
Hemodynamics, can you show the hemodynamics? So we know how it. So I cross the lesion. So just a polishing run. Yeah.
Now,
So
in this particular case, we have put a pacemaker.
Any cocktail for, any cocktail for like adenosine and nitro to prevent no reflow, or you don't do it anymore?
Yeah. So no. What happened is in this bag, the rotablator bag, the flush bag, we have both nitroglycerin, verapamil, and heparin. Now here coming out. Yeah. So all that combination, 5 milligram of nitroglycerin, 5,000 heparin, 5 milligram verapamil in 1 liter bag. And of course, clearly those micro has shown now, if, after the orbital atherectomy came, there was no, we are not putting any of those flush in the bag. And we said, why don't we do with the rota also? And I can tell you personal experience. So in about 2 months, we stopped putting those combinations. And we found that once we don't have this rota flush, the adjunct, that we start having some slow flow. Slow flow will occur in about 2 to 3% of cases. But with that, we started seeing a little more. And therefore, we went back to this combination of the rotablator, putting 5 milligram of verapamil, 5 milligram nitroglycerin, 5,000 heparin.
Put the lights on.
Perfect. Roberto, I think that João has a question, right, about pacemaker. Did I read it correctly? João, do you want to go ahead and ask your question?
No, I can tell you. So I was saying that about the pacemaker issue was basically because right corner is closed and it's the left main. So many of the left main, the complex bifurcation we have seen, once it touches the distal part of the left main ostial LAD, you start seeing the asystole. So, and in this particular case, because RCA is total. So because of that, prophylactic. Now, is it 100%? No. And we learned that also those who want to avoid putting a pacemaker, we have a very simple cocktail strategy. We did actually a trial called BART, B-A-R-T, back in 1996, 97, when we were talking about pacemaker versus so what you need to do is give 1 milligram of atropine and 5 milligram per kilogram of aminophylline IV before your bolus, before you start your rotablation. So that usually 300 milligram of aminophylline and 1 milligram of atropine. So that combination, actually particularly radial case, you don't want to go to the vein in the groin in those cases. So you just want to do the aminophylline 300 milligram and 1 milligram atropine. So that works very well for those cases. But in this particular case, knowing that, I can just tell you that maybe it's the dependency on the support devices which makes our procedure so safe. Despite complexity, we wanted to go with everything possible. And this was one of the reasons was this the graded step bar approach and this pacemaker. Good. Same thing now, the 2.15 bar require 8 French guide. 2.0, you can go through 7 French, 8 French guide. You need a 2.15 bar, which will go through 2.15 and 2.25. More than that, you need a 9 French if you need a 2.38 guide.
Oh, even this is like flying.
Any comment regarding the Rota wires because of the support once your catheter is not that engaged? Any tip from that, Dr. Sharma?
Yeah, so key is that very simple in those, the wire is quite sturdy. So even with ostial lesions, as long as you are aligned, coaxial alignment, your burr will go. So it don't have to be, and I always say, don't bring your guide into the ostium or proximal ostial RCA lesions or the left mains, because the guide itself will create a trouble. Because wire will go very nicely, but has to be aligned. You see that in the line, you cannot be lifted up and you cannot be below. So as long as you have that and change the wire position few times, hopefully the burr will become a little eccentric, modified, I would say orbital type situation.
Okay, start coming out.
Yep, we are ready to come out.
Okay, wait.
How many rotations are you using on that?
Yeah, most of our rotations are 150,000 RPM. Now, rarely, when you are done 4 or 5 times and burr does not cross, then you can go up to 170, 180. But we, by and large, we do 150. I know there is a small randomized trial, 150, 150,000 RPM.
But 150 with every size of
irrespective. Yeah, that is correct.
Okay.
Very good point. So your point is original recommendation, take a picture, let's why. Original recommendation was that you'd use a higher speed with a smaller burr to 160, 180, and then 150, 160 burr less than 2 millimeter, more than 2 millimeter, you go with a 160, 170 and 180 plus with a burr less than 2 millimeter. So that was the original recommendation, but we modified that almost 15, 18 years ago, that low speed is better, cause less chest pain, less slow flow, less perforation. And with the same, although there is a randomized trial of 100 patients with a slow speed and high speed, they compared 150 to 200,000 RPM, and there was no difference in myocardial CK release or slow flow. So yes, we do it routinely, but a small randomized trial done from Germany did not show any difference with a slow versus large. Now, so coming back to the point that if your speed at 150, you cannot cross the lesion after 4 to 5 attempts, 20 seconds each, then you can always crank up the speed, go to 180, and that helps definitely go through the lesion. Efficiency of the rotablation definitely goes down with a lower speed, but in my opinion, it does the job, and it definitely causes a better tolerated to the patient.
Other thing is same, if the single burr that you have, I know we say 20 seconds per run, total of 3 minutes. Once you are done 3 minutes of rota burr, they always say the tip, the diamond chips at the tip of the conical burr actually becomes ineffective. So you may have to change the burr. Usually we say downsize the burr in that case. So now
Kini, I have a question
we took a picture of
if
both.
You want to protect, if you want to protect the left circ, you would do it after rota, right? You never
after rota.
do the wire with a rotablator at the side. Am I right?
Yeah, 100%. You cannot leave any metal when you're doing rotational atherectomy. It will cut it. Metal to metal contact. It will definitely cut it. So you're like now. See that? I will go into the circ. Yeah. Now I'll get into the circ.
But what about to put another wire in the circ, put a microcatheter there, and do like a ping pong technique?
Yeah.
So yeah, there have been certain cases where they have done a guideline. They go with 8 French large guide extension, and they will go guide extension to the LAD and do the burr. And one of the case reports have been there, but we have, like we mentioned, so many cases we have done. So the question will also come, when do you have to protect the side branch? You protect the side branch when the side branch stenosis is very significant. If we are seeing more than 95% lesion of the side branch, you may have to just balloon a little bit of the side branch so it will remain open when you're doing rota of the main vessel. That probably is better than doing any of the technique that have been shown, because at some day we will see there will be, there have been cases where either the guideliner is cut or the rota bar is cut. So those cases have been there, happened. So I think always do this way. That is, you do rota and then wire the side branch. And if you think side branch is significantly diseased, wire the side branch, balloon it so that it will remain open, do the rota, then wire the bifurcation.
Yeah. And I think that's a better approach. I know the one case, the case reports 1 or 2, and people are talking about. I would say one day will get into trouble, because even the studies have shown when you use a rota for the stent ablation, and so you take the bar out and stand under electron microscopy, the diamond coating gets embolized. So it does happen. So, and then of course you always worry about many times.
Rupture.
Many times when we have seen, so this was a 4O cutting balloon at 12 atmosphere. So despite that calcium, it ruptured.
Yeah. So we will go with a high pressure balloon now.
4O, 4O12.
Now, can we show the hemodynamic? It's playing. You see that little ST changes with some hypotension there?
And
Okay, may I
also,
ask a question? You have
Yes.
These large vessels and you do rotational atherectomy. Do you think it's useful to use cutting balloon after using rotational atherectomy, just to make sure you touch the large vessel?
Yeah. Good question, and I'll tell you the reason why. So you saw even with 2.15 bar, the the ablation was very easy, which means based on the IVUS also, the left main circumference was too big for this bar. So in that situation, yes, you need to do cutting balloon. If not, if we thought the burr did a good job by burring the calcium as well as the plaque in the left main, and we had some resistance, in that case, you know that you definitely, ablated the calcium out, then you just do high pressure balloon. And it has to be high pressure balloon, NC, and you go 1:1. So now I have 4.5, 8 millimeter high pressure balloon for the distal left main. This is to make sure the plaque is completely modified, the vessel is completely opened. Now we see some resistance. Okay, good.
There is a question from the audience
Yes.
regarding shock wave. Is shock wave approved for coronary in the United States? Would you use in this case?
Shockwave has not been approved for cases in the United States yet for IVL therapy. Now the question comes is, could we have used it? In this case, could have been, because you have to do one thing, that it's a bulky balloon. We got to make sure that we are able to deliver the bulky balloon to the right place, and I think it would have been okay. In the left main, there's in the trial there's no data of the left main, so I think we will need to wait for some data of the left main before we think we can use it there. Good. How high? So we are going
What
up
about
to
orbital
1820 atmosphere, and you see it's a full expansion. Go up again. I'll see now.
yeah,
But
orbital can be used.
May I ask a question? If you have the shockwave balloon in your shelf, would you use it?
Yeah, so question is very
Yeah, that's
important.
what
So
she said. She would
yeah,
use in this
so-
case.
So
Okay.
I would say that after doing
Increase
the
the pace, sir.
big rota, the question always will
70.
come that what you do, many of these will need to combine, whether
Oh.
it's call it a rotatripsy and a rota cut and all those combinations. So I think that is what we'll do in this particular case. And the question is what size balloon, shockwave and so, and remember it has to be left for longer period of time. And in the left main and you don't have support and you leave it for 60, 90, 80, 90 seconds, maybe a troublesome. So key is that in this particular case, I probably would just go with a quick inflation. And so because of the no support and RCA total. So that will be the reason. But yes, other cases where you want to do in a heavily calcified vessel, large vessel, you do a 1.5 bar.
Sorry, I was circ now.
And then you do the left main, in that particular case, that you do a moderate debulking with a 1.5, 1.75 bar and combine with a shockwave, because knowing the shockwave is available out of United States and it has really taken the momentum. But the question always comes that those who are very comfortable with rotational atherectomy, what will be its role? And I can tell you maybe by next year, when we are live relay, we'll tell you our experience that where we will, because we are so comfortable with a rotational atherectomy, and more importantly, for institutional point of view, there is a separate DRG code for rotational atherectomy, so hospital doesn't lose money, which they used to lose 5 years ago. Now there is a separate APC3 code. Now, whether we'll have that code for shockwave, it still need to be seen, because device is going to cost $2,000. It's still quite high. And knowing the rotablation, all these costs around the same, 2,000 to 2,200.
So in the data they presented during TCT about the IVL therapy, pre-dilation was more than 50% of the case. So what I'm trying to tell you is that the run of the calcific cases, whether it is LAD, RCA, where it is severe disease, a lot of calcium, where we know rotational atherectomy or plus minus OA can do the job, which means that the regular balloon is not going. We do see cases where a regular balloon is not going, even a 1.0 balloon, 1.5 balloon, 1.2 balloon is not going. That's the time when we know rotational atherectomy works in that cases. So if we think 50% of the case requires predilation before you can bring this IVL balloon there, then those have to be maybe moderate, calcium where the lesion is not significant, where this balloon can reach the lesion.
Yeah. I fully agree. And of course, this kind of lesions will have to 100% use imaging. And would you consider to use instead of IVUS, use OCT, because you can maybe see the deep calcium a little bit better with a more high resolution, and maybe add information in which device you're going to select to manage this kind of situation?
Yeah, so let's go back to the situation of, this is distal left main. We could have, selected IVUS versus OCT. I definitely agree. The picture resolution wise, everything wise, OCT is much better than IVUS. That's for sure. But in her case, since her dialysis was questionable, she is back on, off dialysis. We felt we wanted to do the case with very little dye. That is why we opted for IVUS. Now, if it's ostial left main, body of the left main, there's no way you can see it well with OCT. You will have to use IVUS in that situation.
Okay, now you're.
Yeah, this is ostial circ. You see there? It's very tight.
Okay.
Yeah.
So stent in the left, the circumflex is fine. And there is ostial circ disease also. Yeah, right?
Yeah.
Okay.
Now, give the cross-sectional area at the circumflex ostium.
3.5 cutting balloon.
So now what we'll do is, since we do rotational atherectomy of the main vessel, I know there was only eccentric calcium. We already have removed the calcium plus some kind of, debulking of the left main with rota. We could do just a cutting balloon of the circ.
Okay.
Or 2.93.
Yeah.
So can you see the IVUS there of the ostial circ? It's showing a 2.9.
Yeah.
It looked in
So
actually
you're
other
planning
view.
to do you are planning to use two stents or provisional?
Yes. Yeah. No, we are going to do a two-stent technique.
Which technique? Decay?
We will do the mini crush.
Yeah. So, I know that a lot of enthusiasm and the data, which I will show a little bit also once we get a little time about the decay crush and so. But we actually have a very good results, short and long term with our mini crush technique. And this is
so you see the technique I used. I advanced the guide a little bit and just keep forward pressure so that the cutting balloon could make the turn into the circumflex.
Now, this is a 3.56 Wolverine and a 12 atmosphere.
Always Cine document that there's a good expansion. Lesion preparation is a key, especially when you're doing bifurcation stenting. Go up here. We didn't hear the question. Down.
What was the question?
We didn't hear the question.
Good.
Can you hear me now?
Yes.
Yes.
Yeah. Go up.
Good
No.
afternoon. Talking from Miami, not as far away as Brazil. Again, it's always a delight to be working there. It's we all are very appreciative of your outstanding performance.
Down.
Two things. Have you guys, in the setting of peripheral vascular disease, have you guys given thought about using some support of the intra-aortic balloon pump, leading to some degree of support, not unloading, but at least increased coronary perfusion in the setting of not requiring such a large bore access? Number two, the circumflex angiographic didn't look as bad, but of course with IVUS, we now see that it needs to be treated. I've been a big fan of your app for the bifurcation techniques and how or you guys assist on making those decisions. One thing to add is that circumflex angle is very tricky, and rewiring that without prepping that lesion really well would be very tough. So I'm very glad that you guys are doing all this work. You guys going to use mini crush? What are thoughts about DK or culotte?
Yeah, actually, you know, very interesting that culotte we have not been the pro, and with the same the DK Crush 3, knowing the culotte didn't do much better with the DK Crush. Either you go through DK Crush 2, I mean DK Crush, or you go with the mini crush. Yes. So coming back to the issue about the balloon pump, we talked about it before we started the case, and patient left side also has a disease.
3-5-12.
Yeah, so left side also, it was supposed to be revascularized, but that didn't happen. They did a subclavian. So left common iliac also has a disease, and you saw the right. Yes, can we go further through? I think we could have gone through, but then still 2 puncture site and left, that was the only prohibition. But you're right. In these cases, because once we did the cutting balloon, you saw it, we lasted for about 30 seconds, and you're seeing hemodynamics, the blood pressure became 70. So this is the case where I would say that coming back to the point of the IVL will be troublesome, because there you need to leave it for a little extra time to work the 60 to 90 seconds and so. Now we are ready. We have seen the pictures. We have dilated, lesion prepared, both of them. We are ready with the mini crush, putting us 3.5.
We are going to put a 3.512 into the circ. Now going back, DK crush versus mini crush, definitely DK crush. I know the randomized trials have shown, especially in left main, the technique is better. But DK crush has never been compared with mini crush.
Yeah.
Going back to the point that we want to finish this case, sooner, because there is hemodynamic compromise. Can we go back to the hemodynamics there? Because the pressure is on the lower side right now, and now and then gets EKG changes, especially because of the circumflex that's giving collateral to the right coronary artery here. So I think the best thing is, you see how we are going to do mini crush. The steps are faster, and recross we'll have, because of the left main, we'll do pot. Otherwise, normally we only favor kiss and out. So we will do a pot here, since the left main is a larger vessel, and we have a 3-5-12 that will be going to the circ.
May require a little extra support there. Because remember, even cutting balloon going there was very difficult. So we may need another run through wire. Yeah.
That
So
was my
key is that
second
very
point,
angulated. Yeah, absolutely.
The very tough angulation of the circumflex, with maybe using a favorable supportive wire like a Grand Slam.
Okay, so what I did was, you saw that, guide coaxial, again, like I did the cutting balloon, so that the stent could make a turn into the circumflex. Our initial plan with the angiogram, I had picked a 3-5-16 stent, but once the way the cutting balloon behaved, I changed the length of the stent to 12. Are you able to see this movement?
Coming.
Yes.
It's coming there. There's a fluoro save, and you'll see make assignment, and then same. So yeah, good.
So now we are going 4-0-16 left main to LAD. Now the question is same. I think they already mentioned, use the Bifurcate app. We always say go to the side branch, because the side branch angle difficult to deliver the stent. Main vessel usually is a straighter segment and easy to deliver. So that's why we went to the side branch, place the stent, go distal into the into the side branch, and now we are going into the main vessel. So I think this is about right.
Do you have Onyx approved in the United States, the most recent stent from Medtronic that has up to 5.0, 5.5 if you need?
Hold it.
Yeah.
Okay.
Yeah. So no, we actually have Onyx, have both Synergy and Onyx in 4.5 and 5.0.
Okay. Now hold on.
Yeah,
Let me
good.
pull the. What do you think?
Yeah.
Ready? I'm going to take a picture.
Okay.
Everybody.
Guide has to come in a little bit. Yeah.
I don't want to get the guide in.
No, but otherwise you
Okay,
want to-
guys, can you give some blood pressure medication? Pressure is low. Good.
Good.
Okay.
Yeah.
Go up with the circ. Circ is this one.
Yeah. Okay. Ready?
Yeah. Go up
So
quickly.
circ is our 3.5, 12.
Yes.
So this is at 16 atmosphere.
Okay. Down. Go up again. Quick. No, like this.
Good, good. Let's see.
Okay, good. Done. Here. Okay, good.
Your few
Coming out.
millimeter back, and then
No
let's
need.
open the ostium here.
No. I will not describe this in the.
Yeah. Just kind of modified, not truly the DK crush,
Okay,
but now
down,
ostium you open a little better, although it is just the same part. Okay, once it is done, you take out, and all these steps are there in our Bifurcate app, the both wire and
Okay, ready?
Well,
Okay, we have to take a picture. Just make sure we are
Okay.
good. Or okay. Okay, good. Now take out the side branch wire.
Good. Okay.
Okay, go up.
Yeah. 16. Good.
Give me a new fielder. Oh, you know what? Let me see. Maybe I can use the same. So now we will recross. Once we recross, we will do 4-5 pot of the left main and then kiss.
And I know we are getting ready with our second TAVR patient to find out where we are in that particular case.
Don't you prefer to do the pot before crossing,
Yeah.
just to make sure you won't cross below the struts?
So that's a good point. So like a lot of people will do the pot, cross, then repot. And so, yes, that is one way. But other question is that is the right now that pot will help you to go through the strut, right? So key is that if you can get your strut right away with this wire, which is already there, then probably you don't need that additional step because we know that we are going to do a pot. But question is, do you need to do this extra step? So, that is what we are trying to say, that try to get some of the steps out, which are done, which of course everybody decided, so they start doing it. We can pull back the pacemaker.
Why are you on that side?
Yeah, the question is where you try to recross, if you try to recross more proximal or distal in the side branch.
Yeah. So in this one, we definitely will try to go to more distal compared to the little difference in, as
Get
we know,
me a
in the
new
DK
filter wire.
crush, they want to do a little more proximal. So here you try to, if you're not, then right away, then you do the pot. So if we have 4.5 balloon ready. If you need, have we taken a picture? Should we take a picture now?
No. You want to, you can, but I'm trying to avoid the dye.
Yeah.
Okay, you want to? Go.
Yeah.
Take a
Take
picture.
one picture now.
Guys, are you giving something? Why did you take out the pacer? Go.
Yeah.
Why did you remove the pacer?
No, but pacer was the putting it there. The patient there if we need to advance. We don't need it. We can always give a little atropine if need to be. Yeah.
Look at her.
Yeah.
Give 0.6 of atropine. Yeah.
Looks beautiful already.
Yeah. So far, very good. Now we just have to make it, I would say, imaging better. Angiographically, by every definition. But of course, once you have those two stents, you have to have kissing balloon dilatation. So this is where, if you want to see, you want to say that which way, which strut you are going further. So key is that you go into the distal vessel first and then pull back. And now here, we can say this, that you are on the distal part of the strut. See that? Yeah.
Dr. King, my asking what wire you're using for recross?
Fielder. Regular fielder.
No, but we
It's a
don't need
polymer jacketed wire.
Yeah, you want 4.
Now, is atropine going?
Yep.
No,
Yes.
it's
Okay, no
not.
pacemaker. Yeah, just
I'm
no need for
concerned
pacemaker.
about the heart rate.
Yeah.
Exactly.
Yeah, but atropine, if you go, it will be okay. Yeah. Good. So this is but not for the pot. You need to do a side branch first. This is 4.5.
Then give it the pot then.
We are 2.5. These are all the cutting balloon. Yeah, 4 NC.
This is a 4.5. We're going with the 458 to pot, then kiss, and then IVUS. What was the left main? Okay, good. IVUS left main was 4.5. So pot is the same thing. You see that? Okay. You have the thing? Change it. Stent boost.
Which length is this balloon? This NC balloon?
This is a 4.5 NC, 8 millimeter. Yeah, good. Go up.
8 millimeter.
She's
okay.
moving. I don't know.
Why is she moving?
I think the heart rate
18.
is still a little bit low. I thought we had
What
that
have you
pacemaker
given? I know
on,
we
no?
Yeah, we had a pacemaker, but you know, I try not to put a pressure is good. So
nothing.
Yeah. But that's okay. But it's okay. Right now it's good for that way. And want to go a little further? If we need to, we can advance the pacemaker.
No,
again.
you're completely out now.
It looks like a junction, all right?
Okay. Yeah. Yeah.
Go down.
Yeah. So we didn't give verapamil even. Huh? We didn't give verapamil. Yeah. Usually we give either adenosine or actually nitrite. So pot has been done. First, most important is we have to open the ostium of the circ, the stent of the circ. So we have 4O balloon earlier. So you want a new one, a 3.5?
Give me a new 3.5 12.
12.
Maybe the catheter is too intubated, no?
No. Yeah, I can take that, but that's not the thing.
This is a little out. Yeah. We try always, you know, careful to take. Let's open the ostial circ. But that's okay. Why are we worried about pulse rate? Is all right. Good blood pressure. It's okay. No EKG changes.
So now this is a 3.512 high pressure.
Yeah.
Yeah, she's not tolerating that heart rate.
Okay, you may need a compliant balloon here then. So this is after the pot. So if that's the step, if we want to put up quickly the pacemaker again, then we can do it in 1 sec.
Nothing, 1 second.
Yeah. Good.
No,
Yeah, that's what I thought would be the toughest because of that angle of the circumflex is very challenging because of the the 90
2 or
degree.
12, which we need.
Get us a 2 or 12 balloon.
2 or 12 balloon. Okay.
Is connected?
Heart rate is getting better.
Yeah. Good. The pulse rate is about 50.
Get me a run through also. Maybe I need a double wire to get into the circ.
Okay, now we are going with a smaller balloon. Yeah.
Mm-hmm. Yeah,
Good.
to cross the circ. Yeah, it went beautiful.
Other
Yeah.
thing is you don't have to do NC. You just have to go with a non-NC balloon.
Can you see it?
Just to open the struts.
Yeah, this time. Then we can get the high pressure. Ostium a little bit only. Yeah. Good.
Do you have any questions from the audience? Maybe Dimitri can help. Any questions? This is a very fascinating, interesting case and very tough and challenge.
What size is that you have? Now give me a 3.5 regular balloon, 12. And what do we have? Another one, 4.0?
Yeah.
4.0 15 or no?
We have the same 4 or 12.
No, that was 4.5.
No. Yeah, okay, here. Yeah, that's the one. We have 4 or 12.
What we did with 4.5?
4.5, yeah. Yeah.
We feel as if we were in the cath lab. Amazing.
Yeah.
3.5, no? Okay.
Actually, patient never used the pacemaker while it was in. Right? I mean, never used the pacemaker, even during rotational atherectomy.
They left it at 40.
Yeah, but never used it, I'm saying. Yeah. Okay, so now we are, sorry, let's quickly finish it. We are last most important point we're doing now.
This is a 3-5.
Yeah. And this is a
4-12 into the left
LED.
main to LAD.
Yep. And then we do the last IVUS. How far are we in terms of ready there in room 6?
So right now you have 35 minutes for the end of the transmission, right? So if if you finish there, maybe you can see the IVUS afterwards. So
yeah, exactly. So our goal was the same. That probably when you asked that we felt that maybe 1 hour for the coronary case, because a lot of teaching points, and then we have valve and valve tower. Hopefully that we should be able to complete in 30 minutes.
It's not going now.
No?
Maybe.
Perfect. Perfect.
And to rewire it?
This is why we
now,
want to transmit the cases every last Tuesday.
They're ready?
Amazing.
Okay, they're ready.
Can you give me a new balloon?
4-12 non-compliant. So what happened is many times this wires, multiple exchanges, the wire it happens in the smaller guide, but even in the 8 French guide, the crisscrossing, and so particularly happen more with the used balloon. So we are going with the new 4-12.
Okay, good.
Good.
Okay.
Okay. Ready? Yeah. Pull back.
Okay, go up. First with the circ.
Go.
Up 12, 14, 16, 18.
20. Okay. So circ and now the LED.
No, not at that same pressure.
Yeah.
Down.
Again rupture.
Who went that high?
Ruptured this?
Yes, okay. Want to do IVUS now?
Yeah. Good.
Where is IVUS?
Circ ruptured.
Because he went high pressure. How high you went in LED?
The LED went 22. That's good. Okay, here. Let's finish the
IVUS now.
Yeah.
If we have time, we'll do IVUS of both. You have to show quickly the
LED. So I think for interest, everybody will be interested now to how the stent position, expansion, and more importantly for these also to avoid those minor dissections. Able to identify, of course, the OCT does a better job of that. But in this particular case, we decided with IVUS. IVUS is what time tested, ultimate numerous trials all have shown.
Flushed thing. Okay, ready? Closer. Okay, good. Yes. So this is where, we are still in the LED, right?
Looks good.
Tell us when you are close to the distal left main to the circ. Okay. Okay, this is a bifurcation. Well expanded. And look at the left main, well opposed. Yeah. Yeah, proximal edge looks good. Now we are in the, it's not sticking in the
1 millimeter.
It's outstanding.
Yeah.
I think it's a beautiful result.
Yeah. So maybe a one strut has come into the left main.
No.
Although you saw it in the end, right?
No. Cannot
see
be.
That. You'll see.
Cannot be.
Yeah. But all fully opposed. Yeah.
IVUS criteria.
Yes.
IVUS criteria
Maybe just eccentric.
to guide and results.
Sorry, IVUS criteria?
Yeah, say that for the left main, I mean, clearly for the native, for the non-left main, you want to get at least 6 millimeters square and the left main 8.5. So that is the what has shown to correlate with the subsequent lower restenosis and lower MACE. This will be a 12 to 14 in every segment. And the non-left main, you want to get to the, and last picture, we take a low magnification, just in AP view. There you need to have at least 6 millimeters square. But left main definitely should be 8.5. And that is a Korean studies all have shown that really correlate. Now this patient, of course, longer patient get a little bit more, but here very nicely has opened up. Good. And the pulse rate is now 50 plus or 45.
So total contrast, what did you put? 100 cc. And then, oh yeah, fluoro time is only 27 minutes, and more important is air karma was 1.2.
With a DAP of 85. So these are the one now actually very important quality matrix that once you go beyond 15, that you have to talk to the patient, get a consultation, anything 5. We do education, the fellows do. What do you tell the patient if the air karma beyond 5 or DAP?
This is beautiful. I'm very glad that the family refused surgery, Dr. Sharma.
Of course. All right. So if you continue discussion for 2 minutes, we'll get ready for our the valve and valve tower cases where our team is already, I'm sure, done the background. Huh?
You continue talking.
Yeah.
Any questions on this case?
And if you want,
there is a question about dual antiplatelet therapy. In a case like that, with left main bifurcation, for how long should we prescribe the DAPT?
Unprotected left main in this case where there's no other stent, I would give stronger other Eliquis or Brillianta. I think with her case we have opted for Brillianta, so the 1 year should be okay. But if there are multiple stents, then I think you should consider longer, maybe 3 years with that low EF.
So I think that this kind of case with a low ejection fraction, one vessel already down and bifurcation stent, knowing that clearly because of history of CVA, prasugrel is out, and this case will be, got the Brillianta or clopidogrel. We know that old age, all the trials have shown that maybe you don't need such a strong antiplatelet therapy, rather associated with a higher bleeding. So that may be the, one of the factors there. So now if we can just come to some of the slide presentation while they're getting ready, maybe less than 5 minutes, but just to complete lot of discussions which we already have had, and I'm sure all are aware. So point of the left main, PCI versus CABG, all have plus and minus point of it. And we know that Excel trial with the 5-year data, that overall death, stroke, and MI were equivalent. More importantly, I'm sure everybody knows this, that 1 month, if somebody talking about the short-term gain, PCI is better than CABG. At 1 month to 1 year was identical, and only after 1 year we get little advantage of the CABG in these low syntax score patients, which was less than 32 and below. There we know the death issue remain clear cut. Now DK crush, we already have spoken up to the 3-year data of these patients, that 2 stents. Now 2 points I wanted to emphasize. One is the experience of the left main PCI. You see this data very clear. Low volume, they defined as about done in the single digits. The intermediate, when you do between 20 to 30 and more than 35 or so, is your high volume. The mortality of the left main becomes half, from 4 to 2, less than 2% if you get to the high volume operator. So clearly the left main should be done. And what is one of the important reason is the imaging. And I know the imaging, IVUS or OCT, this is the data from the UK registry, that BCIS, that imaging in left main intervention, original data we had from the Korea also, that the imaging is very important, like in this particular case, to get the best outcome. And of course, I think the overall recommendation level will change soon. And the use of the LV assist device, this is the case. We should have used it, but the PAD, we did not. But in those cases, can use a IABP. Like if there is a contraindication, like this case, yes. But problem in this case is even other side also has a disease. And so soon a few other devices will come for this support in the future. orbital versus rotational, where you use one versus other. We have published it, and this is what our data are. And the calcificate, which Dr. Keeney briefly spoke about, with a bifurcate both combination goes quite a bit, and we have a whole, and now we actually new one, which is complicated for coronary complications. And this is not the app, but this is a website for complications. So all types of complications, the device related type really goes to the individual cases and really describe actual cases which have happened in last 10, 12 years at Mount Sinai, go through the theory, what happened, and how they were managed. So all those are become part of this complicated app. Actually not app, it's a website, and very educational. And this is putting all that together, apps which are there. So with that note, I would say that we'll be ready. Dr. Keeney will just take over in the structural room, and I'll be joining there. Really, this was a very complex case, and I hope everybody enjoyed the step-by-step teaching of this mini crush technique. I have nothing against with a DK crush, but I can tell you that by using mini crush at Sinai, you take away 4 or 5 steps, and yet very good outcome. I know some randomized trials are still ongoing in some in Europe and other places, but hopefully over the long-term time we'll know that which technique is better, or both are equivalent. Now Coulot clearly is a little negative just because of DK crush 3, where DK crush versus Coulot, DK crush was better than Coulot. So Coulot I would keep it on the lower side, but mini crush or DK crush, in my opinion, gives us the equal results.
So we are in the hybrid cath lab, myself, and I have Dr. Tang, who is a surgical director, and I have Parasuram, who is the structural attending, as well as Sunny, who is our structural fellow. We have on the echo, Dr. Lirakas, and then we have the anesthesia attending, Dr. Ogan, Dr. Morgan. And of course, the entire cath lab team.
Okay.
Can we show the slides?
And we need those slide advances. Yeah. All right, so sorry for a little delay here, but we are ready to go forward. So this is already moved 1 second, a little fast, good. So this is an 85-year-old patient. Now, just want to make sure that everybody can hear and see things, right? Perfect, okay, but we are hearing very little, very low. Can you hear everybody? Can hear them? Okay. So this is a 85-year-old patient who had a CABG as well as bioprosthetic AVR, 19 millimeter in 2013, and of course it had been on anticoagulation, and it's now presented with the valve degeneration. So very simple. Coronary artery disease is not an issue, particularly here, and severe AS, and we'll show that live. Very quickly, which had been acquired, and you can see here degenerated valve from TE and 3D TE. So, Stem, you can show some.
Yes. So, good afternoon. This is
put the live echo on the screen now.
Yeah, so basically, this is the ejection fraction on this patient is about
echo.
1 second. Yes. Go, okay.
It's about the left ventricular ejection fraction about 35%. The right ventricle function is moderately decreased. This is explained view of the aortic valve. The bioprosthetic aortic valve, as you can see, is severely stenosed. This is with color, a lot of turbulent flow through the aortic valve going forward, and mild aortic regurgitation. This is the left main that we're interested to see after the procedure to make sure we don't have problems. This is the gradient through the aortic valve, max gradient of 59, mean gradient of 39 millimeters mercury, as you can see on the top, the aortic regurgitation. And this is the pulse wave through the LVOT, and putting the measurements by the continuity equation, the aortic valve area comes to 0.4 centimeters square, severely stenosed by a prosthetic aortic valve. And this is a deep gastric view that we will use after the valve is deployed to evaluate the gradients as well for AI and paravalvular AI. Dr. Sharma?
So let's go back to the slide presentation again, please. So this is who wants to talk about this? The valve in valve. This patient has a 19 millimeter trifecta, St. Jude's valve. Gilbert, you want to say on this case?
Yeah, so this is similar to the mitral valve where the pericardial leaflets are mounted outside the stent frame. You can see the signature there on the fluoroscopy. Next slide. So we match it with the CT scan. So the internal diameter is around 17 millimeters. You can see it's a very small valve. Next slide. However, the sinuses are reasonable. The STJ is relatively generous. The left main and the right coronary height are quite low, but because the STJ is pretty large, the risk of coronary obstruction is relatively low here. Next slide.
And in this particular case, at least partial protection is there from Lima to LAD.
Yes.
He doesn't have anything.
Okay,
Yeah.
so the abscess is, you can see it's not terrible, but certainly there's a calcification diffusely on the iliac and femoral. Next slide.
Yeah. So this puts it for tortuosity for the using a sentinel. I know that sentinel actually has come under quite a bit controversy. Some data are plus, some negative, but we try to use in appropriate patients. And at Sinai, doing about 40 the TAVR cases per month, we end up in using sentinel about in 55% of patients, 55 to 60. Part of them is because of the tortuosity of the great vessels is the contraindication.
No, presence and absence of radial.
Radial also, yeah.
Yeah. Now that here is a bovine arch, but despite that, Parasuram and Sunny have placed the sentinel already.
Oh, sentinel already done. Good. Okay, so put it together. This is the patient with the extreme risk with STF mortality of 8+, and here valve in valve TAVR using 23 millimeter Evolute Pro Plus core valve in a 19 millimeter trifecta with the left percutaneous femoral approach and with sentinel protection device. So that's done a great job, and now we are ready with a fluoroscopy.
Yeah. Now show me the flow thing.
Go to the fluoro now.
If you can show the hemodynamics.
And show the hemodynamics also.
And then show the fluoroscopy. I think important point when you're doing prosthetic valve is crossing the prosthetic valve. So I think many of the TAVR cases which we have mentioned in when we are doing our webcast and all that, we normally like AR2 for most of the routes. And if the route is large, then we go with AL1. And then you use, straight angle, straight Terumo wire to cross the valve. But in the case of a prosthetic where we know usually the valve size is smaller, we will go with AR1. So here, just with AR1, whether we saved under fluoroscopy, I think we did. Fluoro save, see? And then AR1 to cross a valve, which we already are there. And you can see the hemodynamics there.
Okay. So we are ready now?
Yeah. So after this, what we will do is go with the confida wire.
Yes.
Yes.
No, there's some question. Yeah.
Yeah, just to know, because even though we have a LAD protected by the Lima, I'm a little bit concerned about the left occlusion of the left main. So I would like to know what is your strategy to do the protection? Will you leave a stent there, do basilica? What you are thinking about? Especially if you decide to do a balloon valve fracture and you can have the valve closer to the left main.
In general, if you concern about coronary obstruction, the fluid is a beautiful point, but you also have functional lines, functional depth to face the lateral and
The problem.
This valve, the trifecta is not crackable. You can remodel it, that's what it's going to do with a 20 millimeter true balloon to stretch it open because it's so net up. But you can see the key for coronary obstruction is the sinotubular junction diameter. If the sinotubular junction STJ size is very small, then yes, your obstruction risk will be very high. But in this case, we can show you the fluoroscopy with the aortogram. It's actually very generous here.
No.
Does it go?
So you can see here, it's very spacious. So the risk of point obstruction is very low in our opinion.
But yes, point is very well taken that with a valve in valve, there is high incidence of coronary obstruction. So had to look into it, and many times you need to do this basilica, which are quite I would say
Time consuming,
tiring, time consuming, and so yeah.
Yeah, but would you consider to do a balloon dilatation before the TAVR to see how
No.
feels the
No.
left coronary?
No.
Not for the coronary, but we just mostly for the implantation because the internal diameter is only 17 and the inflow of a 23 evolute is 23. So there's quite a bit of mismatch. So to optimize the implantation, we would pre-dilate, but we don't think we would need to inject to look at the coronary because the STJ under CT scans are 24, 25 millimeters.
So should you do a pre-dilatation or post?
Pre.
Okay.
And since we are going to be using supraannular, valve, hemodynamics actually would be very good in this case.
Okay. So we have the balloon ready.
Yeah. Thanks.
So what we did, if you see the steps that as we were talking, I crossed with the AR1 and then we went with the regular 300 wire, changed to a pigtail.
Thank you. Thank you.
Once the pigtail is in the LV, then we change to the confida wire. The confida wire already comes with this nice circular, tip that sits in the mid cavity to the apex of the LV. You can see here. Now we are going with the BAV.
Preference between, do you have any preference between regarding support? Any preference regarding the confida, the sapphire, or the Lunderquist double curve?
For the Lunderquist, we only use if the aorta is very tortuous and you need extra support, not otherwise. And for that, you will have to make extra curve. This confida already comes with a pre-made curve. You remember in the early part when we were getting trained, when the curve was not there, the curve was very important. How you make the curve. You cannot have an elbow, which is at the base of the LV, as well as the curve. If you haven't made it well, risk of LV perforation in the early part of our training. So once this particular wire came, pre-made curve, we have been using this wire.
And Safari we use for the smaller LV cavity.
Safari is softer,
soft.
A little softer, but better.
But a smaller LV cavity, otherwise confida is the word choice. Very rarely will use the Lunderquist. Problem with the Lunderquist is it's very traumatic to the vessel. And believe me, I've seen cases of various dissections of the aorta, iliac and all. It's a very good wire in difficult situation, but use it only when necessary. Yeah.
And whenever doing this procedure, you just have to make sure all the team members are aware, especially the anesthetist, the echo doctor, if they're around, they are in the room. Stop pacing. And the technician is listening to one person. You all decide who is that one person, whether it is the first operator or the second operator. They're listening to the pacemaker on and off instructions.
And regarding pacing technique, any preference, especially when you're using these self-expandable valves?
What's happening here, bro?
Don't you consider to pace over the wire?
80, please.
No.
Pace 80. No, so for self-expandable valve, in this, the risk of a pacemaker need is usually very low for valve in valve. So we will use a groin pacement.
And give a little push.
You have a lot of AI?
Yeah. More than the AI at least.
A lot of AI. Okay.
Because this was a true balloon, which we used.
Go.
20 true. And now we are going with the valve and valve with the Evolute.
Okay.
Give the medication, okay?
Pro Plus. Yeah. We need a little push hemodynamic. Okay. Very good. Very good.
Okay. No, pull the wire back. Okay.
We need a TE up.
T up. Blood pressure. Okay. Forget that. Look at the blood pressure.
Okay, we're gonna place it 120. No pressure.
Start giving epi.
We can give epi.
Inject.
Okay.
Oh, all the way.
Good. No, right now we need.
80.
Okay, ready? Inject. Inject. There's no blood pressure. Release it. Release it. Okay, ready?
And still will die.
Inject.
Valve is good.
No, no.
Huh?
No. Bring it. Okay. Really capture. Let's come back. Resuscitate first. We're going to resuscitate. The valve is too high. We're going to pull back and resuscitate the patient.
Okay, that's fine.
Yeah, just release
Pacemaker
it.
is on.
Yeah.
Yes, yes.
Pacemaker is on. Just release.
Oh,
Just release it now. Yeah.
Okay, go.
No,
Okay.
Okay, go. Release.
Yeah. Good. Yep. Okay.
Okay, while it's released,
We need now. You want to give epi directly? We have epi. Yeah. Okay.
Keep giving. We are
No, but you want to give it
flatline.
out?
CPR.
Yeah,
Yeah,
CPR
yeah.
now.
Yeah. So we sometimes give a intra-arterial and LV.
How
epi
much
also.
have you given, epi?
Okay.
Okay, stop. Let's see if the blood pressure is coming up.
A little more push. You want to give intravenous directly?
Yeah.
No, I mean, we used to have epi here. Huh? You want to give it? Take it.
We are going to give epi.
Good. So, yeah, no, you give it.
Yeah.
So we just trying to give some intra with the pigtail catheter into the aorta.
What? She's saying she's giving it.
Okay. Things are coming up slowly and slowly.
LV is coming back. LV is coming back.
Coming back.
Yes, coming back. Yeah.
Good.
Is this
All right.
there to do the echo so we can see what's going on? Yeah.
Yeah. Show the echo.
Yes. It's coming back.
this is 90.
It's coming back.
Good. Yeah. All right. Things are coming back. How is the LV coming back?
LV is coming back. Yeah, nicely. Short axis of the left ventricle. If you're hypotensive, give some volume. But it's back to actually.
Come out. Okay.
Yeah, nicely back.
Okay.
Okay, let's
Okay.
get to the pigtail on the catheter. What's wire?
No AI.
Wire?
The depth is okay.
No AI.
Good.
Stamp.
No AI. Yes, that is good.
So
No.
you'll control the BP. We
No
didn't give
AI.
any epi or anything else in this case.
Peak gradient 15.
Now, as you see that always in this valve in valve, you leave some residual gradient, and that is the size of the original valve. Clearly in particularly the large size valve, with Evolute, you have a much lower gradient compared to Sapien in the valve in valve. That has been those data, but you always leave some gradient, whether it's a Sapien or you use Evolute.
24. It's very dynamic.
Let me talk about that. I need those slides.
Not in this slide.
We go back there.
Okay.
No pericardial effusion. No hematoma.
So how much did you calculate as residual graded stent? 16?
Yes,
Okay, we are doing that.
Yes.
Look, you can see the hemo. Show the hemodynamics.
Peak gradient by echo 15. Peak gradient 15.
And actually by hemodynamics is also 15. Show the hemodynamics, please. We are not doing the corner. Yeah, it's about 15.
Look
10
at
to
that.
15. Yeah.
You are muted.
You're muted.
Alex.
Huh? You saw the left main.
Alex.
So see the left main flow is good.
The trifecta cannot be fractured, but in this case, is that as very small valves, you can gain some space inside the valve with post dilation. Would you consider to diminish or to have a
wants to
lower
show whatever we
gradient
had
at the end,
earlier.
doing a post dilation in this case?
The question is that do we need to go just post dilate now? The question is what should be our threshold? Knowing that this patient is very hemodynamically, collapsed during this procedure, and now we are left with about 15. Will that not be enough? somebody who's 85. Now, younger age, I would say, yeah, need to be a little more aggressive. But in this case, our cutoff has been, we have post-dilated them, but once it is like 30 millimeter or so, 25, 30. Now here, it's less than 15. Huh?
Yeah.
Yeah.
By echo is mean gradient 15.
Yeah, mean gradient is 15. So by echo, and the pressure is also very high. Huh? Yeah. We need to, yep. Actually, I can tell you in this crisis situation, little high pressure is all right. Because otherwise, low pressure goes, everybody's, even doctors, patients, everybody, low pressure becomes low. High pressure is good. So clearly now we have room to adjust. So that has happened. So this particular case, based on this very minimal gradient of about 15 and good valve area, and the valve functioning well, no AI or so, I probably would leave it.
EF now?
No AI. No AI.
EF.
EF is back to norm, back to what it was before, and actually better than that, maybe 45.
Huh?
Also on fluoroscopy, you can see on the RAO view, the envelope frame is well expanded on the 23. So it's not like constrained. So
40%.
if the patient had a cardiac event, I would be reluctant to post-dilate.
No, I would say the most important here is mediated by that the gradient is very little. So 15, because I think the, those data have been shown. It started with the Raj Makkar and Chakravarti. So they went through. So anytime they have less than 15 or so, then didn't go and post-dilated, because all have a little bit of, there are some issues also that you post-dilate can rupture, can affect the leaflets and so. So I would say based on that, the minimal gradient now, no paravalvular leak, no regurgitation, it is reasonable. We can do one good picture, and you see the valve frame is nicely expanded. It's a time to not to do any more further in terms of valve manipulation. Yes, patients still require the little more adjustment of the blood pressure, which is a good thing, which is easy to tackle compared to the low blood pressure, but that's where we are in that process. But I know only a few more minutes left in our transmission, and Dr. Keeney wanted to just emphasize on the her app. Technology has worked so hard on that, and she really want to just talk few minutes just to update on where it is and so. But if that everybody agrees with this, that you can see the hemodynamics gradient is almost minimal. There is no grade less than 10 to 15 millimeter. Valve otherwise working good. You want to just do a 1 aortogram? We are not done yet.
Okay, start.
Good. Take the pigtail out first.
We did do an aortogram.
Huh? We did?
We did. All done.
Okay.
And we showed that left main flow was very good.
Good. Okay. If you see that, let's see the aortogram. Yeah. Good. Good. So left main and all those are very good. Yeah. Yeah. So I think you just have to get the blood pressure monitored a little better. But from interventional perspective, to me, it's a great success in this very challenging case. And with a very small 19, I can tell you that with a 19 millimeter baseline surgical valve, to come out with a gradient of less than 15 is really remarkable. And so now, as I said, we just wanted 2 more minutes. I know that 2 minutes are left in this particular case. And so, yeah.
Take your time. We still have 10 minutes. Don't worry.
Oh, okay. So yeah, good. So meanwhile, so I think any other comments wants to make Gilbert on this? Would you dilate it here? No. Okay. So now Dr. Keeney back into her app. We just wanted to emphasize, knowing that has worked so hard on this and had this opportunity, which we try to do with all our live cases. So Anu, you want to talk about now this calcificate?
Put the camera on.
Yeah.
Can you see this slides there?
Yeah.
Yes.
Yes. Can you hear me? Yeah. I think I know they did mention that a Bifurcate app was something that people have been using. That was the first app that actually we had shown, published. But for calcific lesion, we have this another app called Calcificate, where you can choose based on the type of lesion morphology that you're going to take care of. And then they are depending the degree of calcium. Now, the degree of calcium can also depend whether you're going to do based on the angiography or you're doing a intravascular imaging. Then you can see that if you are then going into like our case, what did we select? It was calcific as well as left main lesion. Then it will, take you to bifurcate, telling how you can handle these cases. So in calcificate, what we showed you today was just rotational atherectomy. You see just in bullet points, very simply describing what is rotational atherectomy, what are the basics of orbital atherectomy, and other one was laser. Everything just simple points and a quick review in this app, and step by step, which people were asking, what's the flush, what's the speed, what's the burst size, what's the guide size, everything has been described, and how to use this various calcific devices. The various apps, people have told me, why don't you put it in one place? That's why we made this cardiologyapps.com. Very simple, cardiologyapps.com. If you go there, all the various apps that we have made, that is available. And this is what we just published about 2 months ago. This is called as a web app. Web app means it's actually a website, but you can also see it on your phone as an app. And it is called Complicate. What is Complicate? Over the last 20 years, the complications that we have seen and we have handled in Mount Sinai, those were the cases we went through, and we just put them into various groups of what are the important one is atherectomy complications, which we were describing. What happens if there was a slow flow? So case by case, we have over 55 cases, more than 280 angiograms. That is why we could not have an app. It was very difficult to have that kind of storage. We have a website, every case with a complication, how complications were managed, and how to prevent it. Description has been given, and this is what is called as a Complicate, where you can see it. So the various atherectomy complications, simple things, even including wire fracture, wire-related perforation, everything, all the case-related cases are there. The various apps that we have said, bifurcation, you already know. OCT, lot of questions were asked. So we have Octade, which also has a quiz, and a lot of cases showing exactly what should a normal OCT look like, calcific vessel look like. Then important is we just showed you, we have done TAVR. What interventionalists are facing right now is if the patient who has had a TAVR and comes back, reaccess of coronary artery is way hard. Okay, so this TAVR catheter is based on our JACC publication, which catheter to use, when to use in the TAVR catheter. And then of course, transeptate is when you're doing mitral procedures, that how can you do a transeptal procedure easily. And calcificate I just mentioned. STEMI app should be available. It is not patient management. It is a communication platform. We should be available in the next couple of weeks. Okay. So these are all most of the apps, and thank you for this opportunity that you guys gave us to show this complex, calcific left main bifurcation lesion, as well as this valve-in-valve TAVR. If you have any questions, we are ready to take the questions.
Beautiful. I think João has a question. João, can you go ahead?
Sure. Again, it's a really, really nice case and very, very well taken care of. Very challenging small valve. My question number one is, given the patient already has a small prosthesis, and I saw the choice was to use an Evolut Pro Plus, which is routinely what we use here, but was there any thought about using Evolut R, giving them not necessarily as much as need of a skirt and try to gain much of the hemodynamics? And the second of all is given the setting, we have the advantage of having Dr. Tang in the room. If there's any thoughts about aligning the sinuses with already the technique being the standard for us.
Yeah, with the commissioner alignment.
So let's go back to the commissioner alignment. I think Gilbert did mention the C-tab. He was telling me, pull the back to the wall. Normally you have to do the alignment down in the descending, so the C tab is facing the right way. but you saw the pressure was 30, and I did not want as alignment here at this particular stage. We just wanted to deploy. The other option would be, then you have to come back all the way down, resuscitate the patient. Patient has to breathe, the blood pressure has to come up, and then go back again to do the same thing. And what also happens is multiple movement of this valve back forth can give rise to, the risk of CVA is higher. We already did BAV, and we wanted to avoid multiple movement of this big device across the great vessels.
Yep. So Commissioner Tab, that's
So actually, in this case, it's interesting. If you could just show the floor for a minute. 1 second, person. Oh.
Can you show the fluoro?
Yeah, so here you can see that this is the RAO called the cusp of the C-tab. Actually, incidentally, was actually in the favorable position. And you can see on TE as well. You can we show echo as well?
Yeah.
The TE, look at the leaflet orientation. On the Mercedes-Benz sign on TE. Yeah, you can see the leaflets also nicely aligned. The left main would be in the 2 o'clock position, or 1 to 2 o'clock position. You can see the leaflets actually aligned very nicely.
Yep. Okay. With that note,
any other questions?
Yeah. Any other questions?
No other questions.
With not that, we are just going to close the vascular closure here, and we really thank for the opportunity, and we end our transmission, and hopefully all your participants will have this lot of educational tips and tricks which they can use in their own practice and to become a better operator to a wide range of patients.
This was remarkable, Dr. Sharma, Kini, and everybody at Mount Sinai. Our best to everybody, our friends, and we're looking forward to having CCC next year in July, and hopefully that you're going to do other interesting cases in December as well for your course, right?
Yes, that is correct. Yes. Okay, thank you very much.
Your final words.
Namaste.
Roberto.
Namaste.
Namaste. Namaskar.
Great.